Good morning. A case of confusion. We have first to differentiate between it is acute or chronic confusion or acute on top of chronic. Acute confusion that develop over few days, maybe 2 to 3 days. Acute confusion start abruptly. Chronic confusion start gradually and progress over years. Acute on top of chronic means that the patient has some problem in his confusion and cognitives, and abruptly he developed acute confusion. What is the most common cause of acute confusion or delirium? Acute confusion, it means that the causes could be related to most important neurological cause. Neurological cause like stroke, and this stroke is not internal capsule, but it should be cortical. Number two, maybe this patient has hemorrhage. Hemorrhage like intracranial hemorrhage or subdural hematoma. I know well, subdural hematoma is one of the causes that lead to fluctuation of the conscious, but could be start acute, then after that will proceed fluctuation of consciousness. Number three could be epilepsy. Epilepsy, one of the cause of acute confusion. Now, if we look for neurological cause, we check the cortex. The problem in the cortex. Number two, the problem in blood vessels, like hemorrhage, or maybe related to subdural hematoma. Could be also related to infarction in brainstem. Number five could be infection, like meningitis. يبقى to revise again the neurological cause of confusion, acute. Again, acute confusion could be cortical stroke, could be stroke in the brainstem, could be this patient has intracranial hemorrhage, subdural hematoma, could be this patient has epilepsy or infection like meningitis or encephalitis. Then we'll go to cardiological cause. What is the cardiological cause of confusion? If this patient has bradyarrhythmia, Adam stock attack. If this patient has tachyarrhythmia, could be the patient become confused or acute severe myocardial infarctions. I mean by acute severe myocardial infarction, the patient has cardiogenic shock. يبقى we have neurological, we have cardiological causes, then look for loss. I mean by loss, decreased cardiac output can lead to also confusion. Decreased cardiac output may be severe anemia acute by hemorrhage or severe dehydration by losing of fluid. يبقى hypotension أو due to anemia or due to dehydration. Both lead to confusion. Then metabolics. Metabolics like disturbance in electrolytes, hypokalemia, hyponatremia, hypomagnesemia, hypophosphatemia, or hyperkalemia, hypernatremia as well. Maybe this patient had disturbance in acid-base balance, like severe metabolic acidosis or respiratory acidosis as well. Maybe this patient disturbed in blood glucose, hypoglycemia could be also one of the cause. Could be also multi-drug user, especially in the old age. Another than multi-drug user and the commonest in the old age, infection, one of the causes of the acute confusion, either urosepsis or pneumonia. To revise again, all these causes would lead to acute delirium. What is the causes of chronic delirium? Chronic, some of them is reversible, some it is not reversible. Not reversible like Alzheimer's disease, or patient has Parkinson and he develops dementia or vascular dementia. Could be reversible like vitamin B12 deficiency, like hypothyroidism. All causes of acute delirium can precipitate acute confusion in the patient has chronic confusion. How can we approach to a case of delirium? First, have to ask the patient or the surrogate in the exam what happened before this attack developed. You have to ask all risk factor of stroke. You have to ask about trauma. You have to ask about any fever, any travel abroad, any neck rigidity. You have to ask any family history of the same condition due to intracranial hemorrhage, due to rupture AV malformation. And ask if the patient has any memory affection before, to check if the patient is acute on top of chronic or the patient acute only. And ask about psychiatric problem. يبقى we have to revise the risk factor of neurological cause as we mentioned, risk factor of cardiogenic cause as that we mentioned, risk factor of metabolic, and revise the drugs. The most important to ask the patient or the surrogate in the exam what about his memory before. Then during attack, if this patient lost consciousness or not, if the patient regain his conscious without help or not, because hypoglycemia reversible with sugar or fruit. And ask about any fits happen during attack or not. Then after attack, if the patient has fluctuation consciousness, here again he's conscious completely or not. This is how to approach to acute. For chronic, you have to ask about sign of hypothyroidism, sign of vitamin B12 deficiency. If no sign of hypothyroidism and the sign of vitamin deficiency or no signs, vitamin B12 deficiency or no sign of metabolic disorder, ask about memory. What about the memory of the patient in details? Recent and past memory, about his social activity. If any change in his social activity, about his mood, any disturbance in his mood. Ask about behavior, any change in his behavior. يبقى again, memory, behavior, personal activities, and about his also about his intellectuals, if the patient has mistakes in his work or not. Then ask about some hygiene in the house. If the patient doesn't care about his personal hygiene. And don't forget please to ask about headache. Headache why? I told before, one of the cause of reversible chronic confusion, vitamin B12 deficiencies and folic acid deficiency and hypothyroidism, add for them normal pressure hydrocephalus. Ask about unsteadiness. In conclusion, causes of chronic confusion, Alzheimer's disease, Parkinson's disease, vascular dementia. We have to ask about these risk factors, and could be reversible like normal pressure hydrocephalus, folic acid deficiency, vitamin B12 deficiency, hypothyroidism. We have to ask in analysis about memory, behavior, personal changes, about hygiene in the house, and also about his mood, about his gait. This is to approach to acute and chronic confusion. Good luck.